Analyze this chest X-ray that we have sent it a few days ago. This patient clinically presented with worsening shortness of breath and chest pain. It started suddenly 2 days ago. The patient reports having excessive exertion prior to the uh, the event of the chest pain, the sudden chest pain and sudden shortness of breath that awakened the patient from sleep. The possible findings on this chest X-ray is that we are having, it is a clear, good quality X-ray, just visible vertebral column behind the heart. Okay, the trachea is central. Okay, there is no much rotation. What we can see is that there is right lung edge at the left, at the right hemothorax, with a very large pneumothorax. As you can see, the lung markings are absent in the right side, while they are intact on the left side. Uh, the lung is collapsed, completely collapsed, okay, by this large pneumothorax. The patient has a saturation of 92 at room air, and he is dyspneic, but there is no tension. As you can see, there is no deviation of the trachea, and there is no flattening of the diaphragm. So this is not a tension pneumothorax, but it is a large. And with the given history, the patient and the progressive shortness of breath, I think the patient has an immediate need for relieving this pneumothorax. So we send him for chest tube insertion. The important point to recognize is that there is this hyperlucency in the right hemithorax with the absence of lung markings, which indicate pneumothorax, large pneumothorax. There was hyperresonance on the right side with reduced intensity of breath sounds clinically. So this is a clinically diagnosed pneumothorax that was confirmed by chest X-ray. And because the patient has no evidence of tension pneumothorax like severe hypoxia, the deviated trachea, we sent for the chest X-ray, which confirmed the diagnosis. The treatment is by aspiration and chest tube insertion because the patient has evidence of COPD previously.